In this lecture on allergies, we're going to cover allergies in general. That is the IgE-mediated diseases you have to know how to handle. And then we're going to talk about those diseases which are commonly tested in pediatrics, even though adults can get them too. When you start talking about allergic reactions, I want you to separate them: acute allergic reactions and chronic. Now, what we're not going to talk about is all of immunology. We're going to stay focused on type 1 hypersensitivity. That is the IgE-mediated type of allergies. We talk about other diseases in the dermatology lectures, and so that will be the place where you cover immunologic rashes. I really want to go down allergies, what we think of when we think of allergies. So the pathogenesis is going to be IgE-mediated. That is, there will be an exposure to a trigger. It doesn't matter what that trigger is. And what you'll have is cross-linking of mast cells. And these mast cells will then degranulate, and you'll have release of histamine. And it's this histamine release that generally mediates the type 1 hypersensitivity reactions. As you begin studying these diseases in the acute section, what you need to be able to do is separate the person who is having anaphylaxis, that is life-threatening illness, versus someone who just has a rash, that is urticaria, and separate that also from angioedema. You'll see how they can closely relate by the end, and hopefully you'll be able to identify in a vignette or in a patient which one the patient falls in. We're going to start with anaphylaxis because it's the biggest deal. In anaphylaxis, you have urticaria. That is, you're going to have the rash. Usually that rash is all over the body, and it is clear that they're having some sort of immunologic response. And this is the big thing, anaphylaxis will have hypotension. It is the low blood pressure, in addition to the allergic reaction found on the skin, that's going to say that person is anaphylactic. Now, part of anaphylaxis is also going to be the wheezing and the loss of the airway. So wheezing, hypotension, and rash on exposure to some trigger is going to tip you off that there's anaphylaxis. Now, if you make that diagnosis, there's no time to confirm it. The diagnosis is clinical, and the treatment is going to be to save the person's life. The answer on the test is going to be epinephrine. The answer in real life is epinephrine, 1 to 1,000 IM. The EpiPen, you stick it in their thigh, you get the epinephrine in them. Don't wait for IVs, don't wait for anything else, get the epi in. What that does, clamps down the blood vessels, reversing the hypotension, and also helps the airway open up. But you have to know more than that for the ward, so if you diagnose someone with anaphylaxis, you give them the epi. But remember, it's histamine release. So what you can do is give them H1 and H2 blockers. And since this is all immune mediated, giving them steroids will also help lessen any subsequent reaction. The answer you're looking for is epinephrine if there's anaphylaxis. Urticaria is the rash. So what you're going to see is a wheal, a welt, or just some erythema. You're going to get exposed to the allergen, the trigger, and you get a rash. But there is no hypotension. And that is what differentiates that immunologic rash from anaphylaxis. The diagnosis here is also clinical. And usually, urticaria is self-limiting. And being self-limiting, you are then able simply to observe or use topical antihistamines. But if you see a person who's having urticaria, an allergic reaction, the thing you must do is rule out anaphylaxis. Because if they have anaphylaxis, you treat them with epi. Now, one of the things that comes up, and as you'll see more about this in the trauma lectures, Bites and Stings, is what do you do when you get bit or stung, particularly for people who have bee allergies? If there's anaphylaxis, you treat them like anaphylaxis. If there's not, then you simply can remove the pincer without trying to inject more venom and just pull the thing out. They get a little bit red wheal, you treat it with some topical stuff, they get better. Now, angioedema is a little different. Angioedema is going to be swelling, but it's not a wheal, it's not urticaria. And it is going to be almost always on the test associated with an ACE inhibitor. No other medications can do it, and yes, C1 esterase deficiency is a thing, but it's extremely rare. Look for exposure to medication and then swelling. Now, you can swell anywhere, but the way they're going to get you is by swelling the airway. They may even present with inspiratory wheezing or stridor because the airway is closing off. Angioedema usually has swelling in one spot. You're not going to break out in hives and rash all over the place and be hypotensive and have a problem with your breathing. So there is no hypotension. The diagnosis is clinical. And the treatment for angioedema is to secure the airway. And because we're talking about it in the setting of histamine release, and it's a type 1 hypersensitivity reaction, sort of, people will give H1 and H2 blockers. And people will give steroids. Now this, plus minus H1, H2 blockers plus 1 steroids, is a conversation you should have on the wards. Usually people do it because, are you sure that it's angioedema and not urticaria? I don't know. And what's the tolerance of H1, H2 blockers and steroids? Pretty tolerable. And if it is going to help at all, it's worth giving. But you'll notice the difference. Secure the airway for angioedema, epinephrine 1 to 1,000 for anaphylaxis. Both of them may involve wheezing of some kind or airway compromise on exposure to a trigger. But one is going to have a rash all over with hypotension, that's anaphylaxis. One is going to have no hypotension, just that rash, that's urticaria. And one is going to have swelling of the airway with no rash, no hypotension. By the way, if you have C1 esterase deficiency and you get angioedema, you can give FFP. That's for the 270s. Let's transition and head over to the chronic conditions. And the two that come up the most on the test are going to be allergic rhinitis and allergic conjunctivitis. Now, you've probably had this, right? The season changes, your eyes get watery, and your nose runs. It's your allergies. So yes, that's what most adults experience, but the test is going to present allergies in kids because of the unique way it presents. So the trigger is going to be either seasonal or perennial. And what we're talking about here is seasonal is going to be ragweed, pollen in the spring and fall when the leaves change. And perennial are going to be those things that are around all the time. Smoking, dust mites, pets. And what you're going to see in a kid is going to be the allergic shiners. Big bags under their eyes because histamine release causes vasodilation. You might also see the allergic salute, where kids wipe their nose up. They actually create a crease in their nose. If you see the words pale, boggy mucosa, or polyps with cobblestoning, they're pushing you to allergic rhinitis. The cobblestoning is from the postnasal drip. The polyps, pale, boggy mucosa is in the nose. And so when you see this, you're like, okay, they're having allergies. And what you might think to do is try to diagnose it. It is a clinical diagnosis. You're going to have the option to do a RAST or skin testing. That is going to be incorrect. You only do that when they are refractory to your therapy or when you want to do a desensitization procedure and you need to know exactly which allergen to get over. Usually it does not help you avoid triggers, nor does it help you decide how to treat. And the treatment is going to be avoidance of the trigger. This is true of all allergies. Just don't go near the cat if you're allergic to the cat. But some people want to have cats and they've got allergies. So the answer on the test is going to be intranasal steroids. That is the, quote, right answer. You also have the option to use H2 blockers, H1 blockers, leukotriene antagonists. These all exist, and they're good medicines for treating allergies. And you might actually stack them. But the answer I want you to pick for the test is intranasal steroids. Allergic rhinitis, allergic conjunctivitis. What's the difference? Rhinitis is runny nose, conjunctivitis is runny eyes. So you're going to have the same pathogenesis, the same diagnostic clues, and the same way of treating it. Don't forget that H2 is better than H1, and you can also use leukotriene antagonists. But what you're going to see is runny eyes. So expect to see those shiners, conjunctival injection, or swelling, called chemosis. They're both effectively the same thing. One is just runny eyes, and the other is a runny nose. And as we bring it to kids only, we're going to talk about food allergies. Food allergies in general, and then we're going to talk about specifically milk protein allergies. Food allergies are going to come in two forms. One is the one that kids usually get over as they outgrow it. This is going to be things like wheat, soy, milk, and eggs. Introduce them too soon, baby gets a little unhappy, take it away, baby does fine. Where you have to worry is those that cause full-blown anaphylaxis, and these are usually associated with nuts and shellfish. And if the kid gets an allergic reaction to these foods, they may carry that with them throughout life. The patient is going to present. The person who has a food allergy is going to present with nausea, vomiting, and diarrhea. It is essentially allergic rhinitis or conjunctivitis of the stomach. It just goes. But because allergies tend to run with the A's, allergies, atopy, and asthma, look for kids who might have eczema, atopic dermatitis, or asthma. And lastly, of course, since it's an allergic reaction, even though we have it under chronic, food allergies can cause anaphylaxis. And of course, as you know, if you diagnose anaphylaxis, use an EpiPen, which means that a child who has an anaphylactic reaction to food must carry the EpiPen with them in case they need it. And as always, the treatment is going to avoid triggers. And if you have anaphylaxis, use Epi. But how do you find out if baby is having a sensitivity to food? Well, effectively what you do is a food trial. You withdraw all potential offending agents, and you reintroduce those foods one at a time. If baby develops nausea, vomiting, diarrhea, or atopic dermatitis, which we talk more about in the derm lectures, then you say, okay, that's the food that did it, we need to avoid that. And of course, if you find out baby has anaphylaxis, it's usually pretty sudden, and so there's usually a quick association with what they just ate. But then lastly, the special one we're going to talk about is milk protein allergy. And this is specifically from soy. What's going to happen is you're going to have nausea, vomiting, and diarrhea. Soy, just a food allergy. But you could present with a bloody bowel movement. And bloody bowel movement usually gets parents freaked out. But the way it's likely to show up on the test is not just a little nausea, vomiting, diarrhea. It's going to be the kid who has a failure to thrive. Despite feeding adequate amounts and in sufficient volume and frequency, the kid just doesn't grow. And the kid doesn't grow because he's eating soy formula. The diagnosis is going to be clinical. You notice those things and you see that mom is using that formula. And the treatment is to change formulas. Either use cow's milk, breastfeed, or use hydrolyzed formula. Right, to hit it real quick, acute, separate anaphylaxis from urticaria, rash all over. Anaphylaxis has hypotension and wheezing, use Epi. Urticaria just has the rash, no hypotension, usually self-limiting, but you can use topical antihistamines if you want to. Angioedema is not going to have a rash anywhere, it's just going to swell, and on the test it will be swelling of the airway, so secure the airway. H1, H2 blockers and steroids probably don't work. On the chronic side, identify allergic rhinitis and conjunctivitis. You get exposed to an allergen or a trigger, your nose runs, or your eyes get runny. Don't do any advanced testing. Simply use avoidance of triggers, intranasal steroids, and recognize that it's okay to use H2 blockers, H1 blockers, and leukotriene antagonists. Food allergies, identify the things that will cause nausea, vomiting, diarrhea, and be associated with eczema. Food trial, avoid the triggers. Versus those things that will stick with the baby, nuts and shellfish, that cause anaphylaxis, avoidance, and epi. Milk protein allergy, just identify the kid who's having failure to thrive and change the formula. That is allergies.